Imagine hearing a sound like bubble wrap popping, not in your hands, but like deep inside your own chest.
Right. Right next to your heart.
Yeah, exactly. Every single time your heart thumps, you hear this crunch, crunch, crunch. And well, that sound is basically a ticking clock on a lethal anatomical disaster.
It's terrifying to even think about.
It really is. Welcome to today's deep dive. We're looking at this massive, really dense stack of surgical and pathological notes today. And it's all focused on a structure that, honestly, you probably ignore hundreds of times a day.
Right, the human esophagus.
Exactly. Because if you're like most people, you probably just think of the esophagus as this simple plumbing pipe, like a basic gravity-assisted tube connecting your mouth to your stomach.
Which is a huge misconception.
A total misconception. Our mission today is to completely dismantle that idea. Because the esophagus is not just a simple pipe. It's this highly complex, fiercely hardworking, and frankly, dangerously vulnerable highway. I mean, mechanical, chemical, and structural disasters can and do strike it all the time.
Yeah, and that crunching sound you mentioned earlier, that is actually the clinical hallmark of one of those exact disasters.
Right.
When you look past the surface anatomy, you start to realize this 25-centimeter organ is essentially doing a high wire act every single time you swallow.
Every single time.
Yeah. So we're going to explore exactly how this structure manages perfectly orchestrated pressures, why its unique cellular makeup leaves it so exposed to rapid spreading cancers.
And the truly bizarre emergencies that can just tear it apart.
Exactly.
So getting right into the source material, this structural tightrope walk actually begins incredibly early. Looking at the embryology data here, the setup for disaster starts as early as the 4th week of embryonic development.
Right. At 4 weeks, the fetal foregut is so to divide cleanly down the middle. It forms the trachea in the front and the esophagus in the back.
But that separation process is super delicate, right?
Extremely delicate. And it goes wrong quite often. The most common anomaly, which makes up like 85% of these malformations, is something called a type C tracheoesophageal fistula.
Or TEF.
Right, TT. So this is essentially where the plumbing gets completely crossed. The notes say the upper part of the esophagus just ends in a blind pouch, like nowhere near the stomach.
And it just stops.
And then the lower part of the esophagus mistakenly connects directly into the windpipe.
Which is an absolute disaster because anything swallowed goes nowhere, and stomach contents can just travel straight up into the lungs.
Oh, wow.
And what makes this even more complex is that it rarely happens all by itself. It's often part of what pediatric surgeons call vectoral anomalies.
VACTOR, that's an acronym, right?
Yeah, it stands for a cluster of birth defects. Vertebrae, anus, cardiac system, trachea, esophagus, renal system, and limbs.
That is a lot.
It is. Basically, when the midline of the embryo misfires, it tends to just misfire across multiple systems all at once. And the data points out that doctors can actually spot warning signs of this before the baby is even born, which is wild. They look for a condition called polyhydramnios.
Right, an extreme excess of amniotic fluid in the womb.
Because normally a fetus actually swallows amniotic fluid to regulate the volume, right? But if their esophagus is blocked by that blind pouch...
The fluid just backs up.
Exactly. It just accumulates. It's crazy to think about. Like, even before we take our first breath, this tube has to be perfectly engineered.
It really does. But, fast forwarding to a fully formed adult, the engineering is just as fascinating.
Oh, definitely.
Geographically, it spans from your 6th cervical vertebra right around the base of your neck down to your 11th thoracic vertebra. And it is exactly 25 centimeters long.
But the notes highlight that surgeons don't use external landmarks to navigate it?
No, they don't.
Yeah.
They measure the geography from the inside out. They start from the front teeth, the incisors.
Right, because if you're like feeding a scope down a patient's throat in an emergency, you don't have time to look at their spine. You need to know exactly how deep you are based on the markings right there on your equipment.
Exactly. So 15 centimeters in, you hit the upper sphincter. 25 centimeters in, you pass this critical juncture where the aorta and the main airway cross directly in front of the esophagus.
And then at 40 centimeters, you hit the diaphragm, right before the stomach.
Right. But what's truly bizarre about this 25-centimeter stretch is that the actual building materials completely change halfway down.
Wait, yeah, let's talk about this.
The upper third of the esophagus is striated muscle. The middle third is this, weird mix. And the lower third is entirely smooth muscle.
Which, I mean, why swap out the muscle types? It seems like a really strange design choice for a single conduit.
Well, the transition of control dictates those materials. Striated muscle is voluntary. So when you make the conscious decision to swallow a piece of food, you are actively firing those striated muscles in your throat and the upper esophagus.
Okay, that makes sense.
But once that bite is in transit, your brain needs to put the whole process on autopilot.
So the smooth muscle takes over.
Exactly. Smooth muscle is involuntary. It seamlessly takes over in the lower two-thirds to just systematically milk that food down into the stomach without you having to dedicate any conscious thought to it at all.
Okay, let's unpack the structural anatomy a bit more because this next detail in the source material completely blew my mind.
The lack of serosa.
Yes. The surgical pathology explicitly notes that the esophagus has, quote, no serosa. And like most of our digestive tract, the stomach, the small intestines, they're wrapped in this tough, slippery outer membrane called the serosa.
Right, it's a protective layer.
It's basically a physical reinforcement layer.
Yep.
So you're telling me this high-speed transit tunnel, sitting directly in the middle of the chest next to the heart and lungs, was built without an outer shield. Isn't that a massive design flaw?
It is an immense structural vulnerability. I mean, think of the serosa like the thick rubber insulation around a live electrical wire. It keeps what's inside contained. But because the esophagus lacks that insulation, it just sits bare. It's totally naked against the mediastinum, which is the delicate space holding your vital chest organs.
Right.
So if an infection or a tumor starts growing in the wall of the esophagus, there is literally no outer barrier to slow it down. It can immediately invade the surrounding tissues.
And the internal drainage system makes it even worse, right? The notes describe the lymphatic drainage in the esophagus as longitudinal submucosal.
Yes. Rather than lymph fluid draining laterally, like straight out to local lymph nodes, it flows vigorously up and down the entire length of the tube inside that submucosal layer.
So it's essentially an express elevator with no doors on the middle floors.
That's a great way to put it.
If cancer cells breach that lining and get into the lymphatic highway, they just bypass the local tissue entirely. They can drop off malignant cells way up in the neck or way down in the stomach before doctors even know the primary tumor has spread.
All right, the pathology data calls this skip metastasis, and it makes tracking and treating esophageal cancer an absolute nightmare for oncologists.
Because this naked, unshielded highway is so structurally vulnerable, it relies completely on perfectly orchestrated internal pressure to keep things flowing safely in one direction, right?
Absolutely. Under normal baseline conditions, the resting pressure of the lower esophageal sphincter, the LES, which is the valve at the very bottom, it sits between 10 and 25 millimeters of mercury.
And when you swallow, a coordinated wave of peristalsis pushes the food down at a steady 3 to 4 centimeters per second.
But the physics can break down in both directions. If the pressure at that bottom valve drops below 6 millimeters of mercury, you get GERD.
Gastroesophageal reflux disease.
Right. The door's basically left open, and stomach acid just washes right back up.
Which burns.
It does. And when standard medications like proton pump inhibitors fail, surgeons actually have to physically rebuild the valve. They do this using a Nissen 360-degree wrap.
Okay, wait, I was reading about this. They literally pull the upper part of the stomach up and wrap it completely around the base of the esophagus.
Yeah, a full 360 degrees just to choke off the reflux. It creates a brand new high-pressure zone.
But the notes also mention a toupee 270-degree posterior wrap and a door 180-degree anterior wrap. If the goal is to stop acid, why wouldn't they just wrap it 360 degrees every single time?
Well, because if you do a full 360 wrap, you're essentially turning the stomach into a roach motel. Food can check in, but absolutely nothing. Not even a burp can check out.
Oh, wow.
Yeah, the data mentions severe gas bloat syndrome.
Right, so if the patient's esophageal muscles are already weak, that food is just going to hit a brick wall at the bottom, right?
Exactly. That is the exact danger with connective tissue diseases, like scleroderma.
Yeah.
The disease destroys the esophagus's ability to squeeze effectively, so the peristalsis is already compromised.
Got it.
If a surgeon does a full 360 wrap on a scleroderma patient, the weakened esophagus won't be able to generate enough force to push food through that tight new valve. The patient simply wouldn't be able to eat.
So they have to compromise.
Right. They do a partial 270 or 180-degree wrap to limit the acid damage without creating an impenetrable barrier for the food.
That balance of physics makes total sense. But let's look at the opposite extreme, when the pressure violently spikes. The notes talk about a condition called achalasia.
Yes, achalasia is a complete failure of relaxation. The pressure at that lower valve skyrockets above 45 millimeters of mercury, and the nerves that are supposed to tell it to open, They simply degenerate.
The inhibitory neurons just die off, leaving the valve clenched shut permanently.
Exactly. On a barium swallow X-ray, this creates a really distinct visual called a bird's beak.
Right, because the upper esophagus becomes massively dilated, just stretched out like a water balloon from all the backed up food and liquid.
And then it tapers down to a tiny sharp point where the valve is spasming shut.
And because absolutely nothing is getting through, the normal bubble of air that everyone has resting inside their stomach, it just disappears. You see an absent gastric gas bubble on the scan.
Yeah, it's very clear on imaging. Then you have the hypercontractile disorders like diffuse esophageal spasm or DES.
Where multiple segments of the esophagus clench randomly and simultaneously, right? Instead of in a smooth downward wave.
Right. On imaging, it contorts the esophagus so violently it looks like a corkscrew or a rosary bead.
Which leads us to the terrifyingly named jackhammer or nutcracker esophagus.
Those names are not exaggerations.
In this condition, the esophagus does contract in a coordinated downward wave, but with catastrophic hypercontractile force. The amplitude hits greater than 180 millimeters of mercury.
It is a phenomenal amount of internal pressure.
And to the person experiencing it, the sheer mechanical crushing force of those spasms mimics the exact radiating chest pain of a severe heart attack.
Yeah, exactly. Patients often end up in the ER thinking they're dying of a heart attack. But pressure issues aren't always functional. Sometimes they're purely mechanical, like steakhouse syndrome.
Oh, this is wild. The data says it's caused by a Schatzky B ring, which is this thin web-like mucosal ring right at the junction of the esophagus and the stomach.
Right, and a person might live with it for decades without knowing it's there.
Until they go to a restaurant.
Yep. They go to a restaurant, poorly chew a chunk of solid meat, usually steak, hence the name, they swallow it, and that solid mass acts like a cork, perfectly lodging into that narrowed ring. Total mechanical obstruction.
So what do?
The treatment is usually physical dilation. A gastroenterologist goes in with the scope and physically tears or stretches the ring open so food can pass freely again.
Okay, so we just talked about how sudden, violent pressure can cause immense pain or trap food. But what happens when the pressure inside this unshielded tube spikes so violently that the physical structure actually blows out?
That's when things get truly critical.
Right. Let's talk about the traumas and the tears, because here's where it gets really interesting. There are two major types of tears highlighted in the pathology, and they are worlds apart in severity.
First is the Mallory-Weiss tear.
Right.
A Mallory-Weiss tear typically follows bouts of severe, repeated retching or vomiting. The sudden upward hydraulic pressure literally shears the inner mucosal lining right at the junction of the esophagus and the stomach.
But critically, this is a superficial injury, right?
Yes. It's like a deep scratch on the inside of the pipe.
Yeah.
90% of the time, the bleeding is self-limiting and just stops on its own. Or it can be quickly clipped during an endoscopy.
But then we have Borhave syndrome, and Borhave is an absolute catastrophe.
Borhave is a spontaneous, full-thickness rupture of the esophageal wall. The entire tube blows open.
The surgical data specifies this almost always happens on the left posterolateral side of the lower third of the esophagus. Why that specific spot?
It's the point of maximum structural vulnerability. The muscle fibers naturally thin out in that specific posterior left zone as blood vessels and nerves enter the tissue.
Makes sense.
Furthermore, it sits right above the diaphragm, where there is way less physical support from adjacent organs pressing against it. So when violent vomiting spikes the internal pressure, that weak spot simply gives way.
And the presentation of Borhave is known as the Mackler triad: vomiting, excruciating chest pain, and subcutaneous emphysema.
Right, subcutaneous emphysema meaning the air you're swallowing and the gas for your stomach are escaping through the blowout and getting trapped directly underneath the skin of your chest and neck.
Which brings us back to the crunching sound you mentioned at the very beginning of the deep dive. Hammond's sign.
Exactly. Because the esophagus has no outer serosa to contain the breach, highly acidic stomach contents, bacteria and air, are violently injected straight into the mediastinum of the cavity holding your heart.
So every time your heart muscle contracts and beats against that trapped pocket of air, it physically squishes it.
Yeah. And through a stethoscope, it sounds exactly like someone stepping on bubble wrap inside the body.
And the surgical window for this is terrifyingly narrow. The notes say if a patient is diagnosed within 24 hours, surgeons can open the chest and attempt a primary repair, physically sewing the ragged tear shut.
Right, and buttressing it with surrounding muscle. But if the diagnosis is delayed past 24 hours,
Yeah, what then?
by then the digestive acids and aggressively multiplying bacteria have liquefied the surrounding tissue. You can't sew rotting tissue together. The stitches will just rip right through.
Oh, man.
So surgeons have to pivot to massive damage control. They drain the chest cavity, place external T-tubes, and often have to surgically disconnect the esophagus entirely. They divert saliva right out of the neck just to stop the chest from filling with more toxic fluid.
That is brutal. Okay, so internal pressure blowouts are one thing, but external invaders bring their own horrors. The triage protocols in the notes for ingested foreign bodies are fascinating.
They really are.
Like, if a child swallows a smooth coin and it makes it down into the stomach, the protocol is just to observe. The acidic stomach and intestines will likely just pass it. But if that child swallows a button battery, it is an absolute drop-everything emergency requiring endoscopic removal in under 2 hours.
Right.
Why does a battery warrant such an extreme rush compared to a coin?
It actually comes down to electrochemistry. When a button battery gets wedged in the wet tissue of the esophagus, the saliva acts as an electrolyte solution. The wet tissue physically connects the positive and negative poles of the battery, completing the electrical circuit.
Wait, really? So it's actively conducting electricity?
Yes, and this triggers localized electrolysis of the water in the saliva, rapidly generating hydroxide gas and an intensely alkaline pool at the negative pole. In less than 2 hours, that localized alkali literally melts a hole completely through the unshielded esophageal wall.
Wow. Which perfectly transitions into the data on chemical burns. The notes point out that there is a massive pathological difference between swallowing a strong acid versus swallowing a strong alkali like lye or liquid drain cleaner.
Yeah, the mechanism of tissue death is fundamentally different. Acid causes what is called coagulative necrosis. When acid burns the tissue, it denatures the proteins, essentially cooking them into a hard, leathery scab called an eschar.
And that hard scab physically blocks the acid from penetrating deeper into the muscle.
Exactly. But alkali substances bypass that defense completely.
Right, because alkali causes liquefactive necrosis.
Yes. It doesn't create a scab. Instead, it interacts with the fats in our cell membranes in a process called saponification. It literally turns the human tissue into soap.
That is horrific.
It is. Because it liquefies everything it touches, there is no protective barrier formed. The alkali just keeps melting deeper and infinitely deeper through the layers of the esophagus.
This is exactly why the absolute golden rule for any caustic ingestion is never induce vomiting. Because if a chemical has just burned or melted its way down the esophagus, forcing it back up subjects the heavily damaged fragile tissue to a second pass of destruction, it almost guarantees a rupture.
Exactly. Now, we also see structural failures that happen slowly over decades of strain. Consider Zenker's diverticulum.
Okay, yeah.
This occurs right at the top of the esophagus in the neck at a naturally weak intersection of muscle fibers called Killian's triangle.
Right, and decades of high pressure from swallowing forces the inner mucosal lining to herniate. It bulges out through that weak spot in the muscle to create a physical sac, like a false pouch, that just hangs down inside the neck.
And the physical symptoms are harrowing. Food gets trapped inside that blind pouch and slowly ferments, leading to horrific halitosis or bad breath.
The notes say patients will regurgitate completely undigested food they ate days prior.
Yes, they even develop a palpable mass and a literal gurgling sound in their neck when they drink liquids.
And to diagnose it, doctors must use a barium swallow X-ray, right? The data strictly warns against blindly inserting an endoscope.
Oh, absolutely. If the camera accidentally goes into that thin-walled pouch instead of the main esophageal lumen, the slightest pressure will perforate it.
Okay, moving down to the lower esophagus, we encounter a vascular blowout, esophageal varices. When a patient has severe liver disease like cirrhosis, the scarred liver acts like a roadblock for blood flow.
Right. The pressure in the portal vein backs up a condition called portal hypertension. If that pressure exceeds 12 millimeters of mercury, the blood desperately seeks a pressure release valve.
And it finds that release in the delicate, thin-walled veins resting at the bottom of the esophagus?
Yes, those veins engorge with backed-up blood bulging out into the esophageal tract like overinflated balloons. If one of those varices ruptures, it is a catastrophic, high-volume hemorrhage.
To stop a patient from bleeding to death, surgeons can use an endoscope to wrap tiny rubber bands around the veins or inject them with a medical superglue. But the most visceral, desperate salvage maneuver in the data has to be the Sengstaken-Blakemore tube.
It is a terrifying piece of equipment.
Tell me about it.
It's this thick tube shoved down the nose or mouth, equipped with 2 inflatable balloons. One balloon anchors it in the stomach. The other balloon is positioned directly inside the esophagus and inflated to 30 to 45 millimeters of mercury.
So you're literally inflating a high-pressure balloon inside a patient's chest cavity to physically crush the bleeding veins flat against the esophageal wall.
Yeah, it's a brute force tourniquet applied from the inside out. It stops the bleeding, but the mechanical pressure is so immense, it risks cutting off blood supply to the healthy tissue, causing further necrosis if it's left inflated too long.
So acute traumas, ruptures, and bleeding varices are explosive split-second emergencies. But there is a slow, silent trauma that fundamentally rewires the cellular landscape of the esophagus over years, leading to the ultimate toll, cancer.
Right. Returning to GERD, when acidic stomach contents constantly wash up into the lower esophagus, the native squamous cells lining the tube are subjected to a daily acid bath they were never designed to survive.
So in a desperate bid for survival, the body triggers a literal metamorphosis.
It does. The flat squamous cells physically transform into columnar intestinal cells, complete with goblet cells.
Goblet cells, which normally live in the intestines to secrete thick, protective mucus, the esophagus essentially tries to turn itself into an intestine to survive the acid.
Exactly. This cellular shift is known as Barrett's esophagus. But this evolutionary defense mechanism comes with a brutal catch.
Right.
By rewriting their genetic identity, these cells become incredibly unstable. The data shows Barrett's esophagus carries a 0.5% risk per year of mutating further into adenocarcinoma.
Which brings up a fascinating geographical divide in how esophageal cancer develops globally. There are two primary factions, right?
Yes.
Squamous cell carcinoma, or SCC, dominates globally, particularly in regions like India. It primarily attacks the upper and middle thirds of the esophagus, and its risk factors are all about direct physical and chemical damage to the native cells. Intense smoking, alcohol consumption, drinking scalding hot beverages, or having scar tissue from swallowing lye.
Conversely, adenocarcinoma is the dominant esophageal cancer in the West. It strikes the lower third of the esophagus, and its primary drivers are exactly what we just described: obesity, chronic GERD, and the resulting Barrett's esophagus.
But looking at the risk factors for adenocarcinoma, there is a paradox in the notes that seems completely contradictory to me.
The H. pylori paradox.
Yes. H. pylori is listed as protective, but H. pylori is the infamous stomach bacteria responsible for causing debilitating ulcers and gastric cancer. How is it possible that a famous ulcer-causing stomach bacteria actually protects you from esophageal cancer?
It comes down to the mechanics of acid production. H. pylori thrives by wreaking absolute havoc in the stomach, causing chronic inflammation. Over decades, that inflammation destroys the parietal cells, which are the specific cells in the stomach lining responsible for pumping out hydrochloric acid.
So a stomach infected with H. pylori produces significantly less acid.
Precisely. Lower stomach acid volume means less acid available to reflux up through a weak sphincter. Less acid reflux means less damage to the lower esophagus, a lower chance of developing Barrett's metamorphosis, and ultimately a reduced risk of adenocarcinoma.
Wow.
It's a perfect, albeit morbid, illustration of how inextricably linked our internal ecosystems are.
It really is. Now, if esophageal cancer does take hold, the surgical interventions are some of the most monumental and traumatic procedures in modern medicine.
Oh, absolutely.
The names alone carry massive weight. The transhiatal esophagectomy by Oranger, the Ivor-Lewis, and the McEwen procedure.
To cure the cancer, you have to completely excise the diseased portion of the esophagus. But doing so leaves a massive anatomical void between the back of the throat and the stomach. You have to bridge that gap.
And the Ivor-Lewis and McEwen procedures are staggering in their scope. Surgeons open the patient's abdomen to physically detach the stomach from its surrounding blood vessels. Then, they open the right side of the chest or even go all the way up into the neck for the McEwen to remove the esophagus. Finally, they pull the entire stomach up out of the abdomen into the chest cavity and sew it directly to whatever is left of the throat.
You are permanently relocating an abdominal organ to replace the naked highway. And the physiological consequences for the patient's daily life are immense.
I can imagine.
The stomach is no longer a large, flexible reservoir. It's stretched thin into a tube, so they can only eat tiny, frequent meals. Furthermore, they no longer have a lower esophageal sphincter to stop reflux.
Because it was removed with the esophagus.
Right, because their new stomach sits directly in their chest. Negative chest pressure actively pulls gastric juices up. They often have to sleep at a steep incline for the rest of their lives. Gravity becomes their only defense against aspiration.
It is a radical restructuring of human anatomy just to survive. And yet, despite these heroic body-altering surgeries, the survival statistics are deeply sobering. The data shows the 5-year survival rate for esophageal carcinoma hovers roughly around 20 to 25%.
Yeah. Because of that lack of a protective serosa and that longitudinal express elevator lymphatic drainage, the cancer spreads silently and rapidly long before a patient ever feels difficulty swallowing.
It demands total respect. It's an anatomical marvel that must perfectly balance neuromuscular timing, intense localized pressures, and aggressive chemical environments millions of times over a lifespan with zero margin for error.
Absolutely zero margin.
So for you listening to this, the next time you take a drink of water or swallow a bite of food, remember that your esophagus is not just a pipe. It is a brilliantly complex, dangerously vulnerable high-speed transit tunnel. We've traced how its tissues transition from voluntary command to involuntary autopilot. We've seen how the absence of an outer shield turns it into a fast track for metastasis.
We've unpacked hypercontractile spasms that perfectly mimic heart attacks,
Full-thickness blowouts that sound like bubble wrap popping inside your chest.
desperate balloon tourniquets to crush bleeding veins.
And silent cellular metamorphoses that trade acid resistance for a ticking cancer clock. It really is incredible.
It is.
I want to leave you with one final thought to mull over. Every single time you swallow an action, you will perform hundreds of times today without dedicating a single conscious thought to it. A perfectly timed 3 to 4 centimeter per second wave is rippling down a delicate, completely unshielded tube resting directly against your beating heart. What other invisible daily miracles is your body executing perfectly right this very second that you are completely ignoring until the moment they break?